Greetings everyone, I hope you're all well. I'm Mariana García Villarejo, a medical intern at the social service of the Ignacio Chavez National Institute of Cardiology. Today we have prepared a case titled Dehiscence of the Aortic Valve, a late complication of Bentall-Bono. We have a 39-year-old male patient, 1.62 meters tall, weighing 64 kilograms. He has an HAAV diagnosis from 2. Regarding his cardiovascular health, he underwent aortic valve replacement with a mechanical prosthesis and a Bentall-Bono graft. He had revascularization of the left mammary artery to the left anterior descending artery. He had trivessel disease and ascending aortic dilation with valve dysfunction this year. Given this history, our patient began with orthopnea 3 months post-valve surgery. He reported cough and pain in the tracheal notch when lying down. A week later, he was admitted to the coronary unit for worsening functional class NYHA4. At this moment, he mentioned having had episodes of fever, but it was not quantified. Vital signs on entry were heart rate 87, respiratory 22, blood pressure 114/78. His temperature was 36.8 and saturation is 89. For the initial approach, we had lab results, highlighting a PCR of 57 and an NT-proBNP of 13,412. Hemoglobin was 11.9, leukocytes were 10. Lactate measures 1.6 and INR is 8.4. The initial transthoracic echocardiogram showed these findings. We can observe a paravalvular leak and systolic collapse of the ascending aortic graft. Thus far, we can summarize our differential diagnoses. Consider hematoma, hemomediastinum, or infection. Continuing with the approach, we requested a transesophageal echocardiogram where we can observe in this short axis. We can see a paravalvular leak. In the long axis, we see a vegetation where systolic collapse can also be observed of the ascending aortic graft. Here we have the same image of the long axis with Doppler. We see the vegetation too, and the systolic collapse of the graft. In this image of the long axis at the level of the ascending aorta, we can observe a hypoechoic image with echogenic heterogeneity, indicative of a hematoma located at the height of the aortic root. A probable infectious endocarditis diagnosis can be made, at microbiology's expense with negative cultures, and later pathology reveals that it is a vegetation with a high leukocyte content. Regarding the review, we would like to bring up 3 important points, starting with the recent update of the European Society of Cardiology guidelines regarding aortic pathology. As Dr. Palomares mentioned in previous videos, we can find as a novelty the cutoff points for the maximum diameter of the aorta, as a recommendation for surgical procedure. In our patient, we must note their risk, elevated calculated by STS score, and those related to the ascending aorta. On the other hand, we have consideration that in addition to the maximum diameter of the aorta, the height of 1.62 and the age of 39 in our patient. As the second point of our review, we have the answer to our initial question regarding the complications of selling the Bentall-Bono. This procedure, which has undergone modification since 1968, has positioned itself the gold standard for treating patients who need aortic root replacement. However, when we talk about recent reviews that follow up for 6 years, we realize that the peak incidence of complications such as mortality, hemorrhage, reoperation, and endocarditis in that order occurs in the first 30 days, keeping in mind our patient visited us 3 months later. As the final point of our review, we recall the last diagnosis we gave our patient of probable infectious endocarditis, according to the criteria set by the European Society of Cardiology in 2020. with an image suggestive of vegetation from transesophageal and transthoracic echo, and a predisposing condition, which was the prosthetic valve. This provides one major and one minor criterion, similar to a probable diagnosis as opposed to a definitive one, resulting from one major criterion and at least 3 minor criteria. As part of our patient's care following a surgical session, it was decided to start antibiotic therapy before the surgery, where the Bentall-Bono was dismantled. A new surgery on the ventral aorta took place, and due to the findings of abscesses at the mitro-aortic junction, a command surgery was performed to reconstruct the mitral valve and fibrous tissue. In summary, to discuss our patient's evolution, we will have that he entered our coronary unit with optimal medical therapy for heart failure, with a reported ejection fractioner of 21%. After the surgical session, where the patient's history and current status were discussed, treatment with cephalothin was initiated. However, we diagnosed an acute kidney injury, and it was replaced with vancomycin. Some previously discussed surgical findings included the dehiscence of the Dacron tube due to abscesses, vegetations, and thrombi. That led our patient to undergo a highly complex surgery, such as this mitral reconstruction. And as expected, due to vasoplegia, a rather complicated postoperative period ensued, resulting in the need for mechanical support to address this cardiogenic shock, with significant drainage that eventually resulted in our patient's death. As a final note, we want to stress the importance of remembering that in patients with cardiac prostheses, endocarditis should be considered as a complication, even without systemic inflammatory response. We know that microbiology and pathology may turn out negative, but this is due to the antibiotics we provide beforehand. Finally, remember that the treatment of endocarditis in patients living with HIV should follow the same guidelines. And lastly, there are metrics beyond aortic diameter that we must consider as predictors of cardiovascular events and for their treatment. Thank you for your attention.